Hello, my name is Laura Meade, and this is my DNP project presentation, Screening for Depression in Adolescents, Administration of the PHQ-9 Modified for Adolescents. Committee members, Ashton Lindsay, Dr. Rita Wunderlich, and Alyssa Bratton. Introduction. The onset of depression is commonly during adolescence. Screening for depression in adolescents is the gold standard, and this is to prevent adverse events related to untreated depression in this population. Phenomenon of interest. Depression is defined as a mood disorder characterized by low mood or loss of pleasure or interest in activities most of the day, every day, for at least 2 weeks. It affects approximately 1 out of every 4 adolescents between the ages of 13 and 18. Interest and expertise. I am a psychiatric mental health nurse practitioner currently working in an outpatient child and adolescent clinic. The focus of my scholarly project is the screening for depression symptoms in adolescents. The purpose was to implement the administration of the PHQ-9A between the ages of 11 and 17 in the outpatient psychiatric clinic where I am seeing patients. And the aim is to adequately screen and detect depression signs and symptoms by administering this screening tool, leading to earlier detection and implementation of treatment interventions. Type of inquiry. The methodology used is a scale to assess adolescents for depression symptoms. It is a quality improvement project. The PHQ-9A was administered to all adolescents between the ages of 11 and 17, presenting for their initial psychiatric evaluation, and the completed PHQ-9A were reviewed retrospectively for the purpose of this project. Depression screening. Again, it is the gold standard for pediatrics and adolescents. It is difficult to implement and maintain. Ideally should begin at 11 years old. Support for this project came from management at the facility where the project took place. It also included their quality improvement team and nursing staff on site who helped with administration of the PHQ-9A. Benefit to practice. The company's policy regarding screening. So the PHQ-9 was supposed to be completed on all new patients. However, it was found that this was not being done at this particular site, and that is why this was chosen as a quality improvement project. Administering this screening tool improves patient outcomes by detecting depression symptoms earlier in treatment. And this project helps by improving compliance to the policies and procedures. Like I said, it was supposed to be being done already, but it was not. Question of inquiry. In outpatient psychiatric patients ages 11 to 17, will administering the PHQ-9 modified for adolescents screening tool upon initial evaluation in comparison to no standardized depression screening increase the number of positive depression scores documented for patients within a 10-week period? Literature review. There were 12 primary research publications that were used for this comprehensive literature review. These 12 publications were grouped into 4 different themes, and the themes were risk factors, health disparities and barriers, screening tools, and implementation and interventions. Risk factors included poor academics, poor relationship skills, isolation, suicidal ideation, self-harming, or even suicide attempts. The biggest risk. According to research, suicide is the second leading cause of death in the world for adolescents between the ages of 15 and 24, with a suicide attempt rate of around 1 million per year. Barriers to treatment. Lack of resources available in the area for mental health care. So this outpatient clinic was located in a rural community. Lack of insurance coverage. Availability of providers in the area. long wait lists for appointments with mental health providers. A lot of research showed at least 6 months for a wait list. Poor follow through of patients and guardians. So this was more related to primary care doctors referring to psychiatry or counseling, and guardians not following through with taking their children to see these specialties. A lack of time available or procedures in place for primary care providers to perform the initial screening for referral. Screening tool. The PHQ-9A is valid and reliable. It is used for patients aged 11 to 17. It has 13 questions, and a score of 4 or more is considered positive, or if somebody answers that they are having suicidal thoughts. This is a copy of the PHQ-9A, and it shows all of the questions and the scoring of 0 to 3, and then you add up the total at the bottom, and any score greater than 4 or greater is positive. And this is the tool that you can use when grading. Implementation and intervention. Screening is necessary due to the risk of suicide in this population. Early screening leads to earlier intervention and improved outcomes. Methods. It is a quality improvement initiative, and it used a quantitative exploratory method to determine whether the intervention was effective and statistically significant. Prior to the project, a screening tool for depression was not being administered at this location, and we implemented the PHQ-9A because it is appropriate for this population. Setting and population was an outpatient psychiatric clinic located in the northern central region of the United States. The population was adolescents ages 11 to 17 presenting for their initial psychiatric visit. Design. So anonymously completed PHQ-9A were utilized for data collection. The minimum necessary data to accomplish the goals for the project were recorded on the data collection sheet. All potential patient identifiers were removed and not collected for this project. And an a priori power analysis determined that a minimum of 18 patients were needed for data collection. Inclusion criteria. So the participant had to be between the ages of 11 and 17. The participant presented for initial psychiatric evaluation at the author's clinic during the study period. And the participant speaks either English or Spanish as their primary or secondary language. Exclusion criteria. If the patient was younger than 11 or older than 17, they were not used for the purpose of this project. And if the patient's primary language was anything other than English or Spanish, they were also eliminated. The participant was already being seen at the clinic for follow-up, so it had to be done at their initial psychiatric evaluation. It couldn't be done in a follow-up appointment. And the participant already completed their initial evaluation prior to the study period. Resources. So support staff consisting of nurses and administration. Office supplies included paper, writing utensils, and ink. Since the provider works at a telehealth clinic, there are also other resources that were being used. So electricity, phone usage for consulting with the nursing staff regarding the project. Budget. The budget for this project was based on the anticipated costs needed for the project. It included paper, pens, electricity, cell phone, and ink. The total approximate cost for the project was $100.55. There was no budget allotment for travel due to the use of telehealth. Protection of human subjects. There were no foreseeable physical, psychological, social, economic, or legal risks that could have resulted from this project. The clinic's location was described as an outpatient psychiatric clinic located in the northern region of the United States without any specifics about the exact location of the clinic, and all confidential identifying information about the patient was removed and not included in the data collection. Analysis. A 1 proportion z-test was performed with information from a sample size of 18, and this was used to determine if the intervention effectively detected depression symptoms based on how many screening tools were positive. There was no pre-data to compare to the post-intervention for the purpose of this project. Data collection. The completed PHQ-9A, and these were anonymous, so there were no names or any patient identifiers on them. The only thing that was added was a number at the top, just number 1 through 18, so that they could be recorded on the data collection sheet. There was a data collection tool that was created by this author, and only nominal data was collected, yes or no. So this is the data collection sheet. So it shows chart number, so the number was just written at the top of the forms. And then PHQ-9A was completed in its entirety, yes or no. So if there were any questions that were left unanswered, then a no would have been put in this column. And then screening positive or negative. So if there was a score that was 4 or greater, it was just recorded as a positive or a negative on here. No actual numerical scores were used. Results. So 12 out of 18 screening tools were positive. And all of these screening tools, once they were completed, they were stored in a locked office, and nobody had access to them other than the author. So there was no information that was stored that was specific to the patient. There was no way to know which sheet belonged to which patient, and they were kept in an area where nobody had access to them. Once the scores were recorded on that data collection sheet, all of these forms were destroyed. So there was nothing left after that had anything specific from the patients. Results. A 1 proportion z-test was utilized to determine the significance of the positive PHQ-9A screening tools. It was expected that half of the screening tools would be positive, so P equals 0.5. Greater than half were positive, since 12 out of 18 came back positive, and the results were statistically significant and showed a positive outcome from administering the PHQ-9A to adolescents. Z equals 1.4142, and P was equal to 0.0786. And these are my results in table form. So there was not sufficient information to suggest a decrease in the ratio from pre to post intervention, and the p-value of 0.0786 was greater than the significance level of 0.05. The achieved power of the study is 0.4122, and that's considered medium in strength. Discussion. Screening for depression in adolescents is imperative due to this population being high risk for suicide and poor outcomes related to depression. According to the results, there was a positive correlation between screening adolescents with the PHQ-9A and identifying depression symptoms. Strengths. So all of the tools were completed in their entirety. There weren't any that had any answers that were left unmarked. There were no refusals, so none of the patients refused to complete the PHQ-9A at their appointments, and none of the parents refused for it to happen either. With them being minors, the parents had to consent to this tool being completed and consent to their appointment. So there were no refusals at all. All were completed in the same manner. So when a patient came in for their initial psychiatric evaluation, They were checked in, signed their consent forms, and they came back with the nurse. And when vital signs were collected by the nurse, she went through the PHQ-9A with each patient and asked them the questions. And they also had a copy to look at, and they could record their own answers. And if they had any questions, they could ask the nurse. If she was not there during the appointments, then this was completed by me. So there was no other outside staff that were not familiar with how to complete the PHQ-9A who were working with these patients. It was either me or my nurse. More than half were positive for depression, so a score of 4 or more. So the project was overall successful. Limitations. There were some patients that did not show up for their appointments. Overall, during this time frame, about 50% of the psychiatric evaluations that were scheduled no-showed for their appointments. So this is something that is kind of unpredictable, and it makes it hard when choosing a time frame for the project, because we needed a number of 18 total, and even though we had plenty of these patients scheduled during this time frame, it was unknown how many were going to show up and how many were not going to show up for their appointments. So if they didn't show up, obviously they couldn't complete the PHQ-9A. There was also the limitation of time. So due to the author only having a limited amount of time before having to move on to the next class to complete the DMP program, it limited the time. Now, we did complete all 18 that were necessary at a minimum. However, having more would have provided more data and would have been ideal, but we worked with a limited amount of time. And like I said, for a minimum number of screening tools, we needed 18, and that is exactly the amount that we got at the very last minute at the cutoff in time. If we would have had more, it maybe would have been a stronger study. Recommendations. So it's recommended that the PHQ-9A or a depression screening tool in general be completed on all adolescents between the ages of 11 and 17 in all settings. Some sort of screening for depression should be happening for any patient over the age of 11. This should be happening either at their therapist or counselor appointments, a psychiatric evaluation, their pediatrician's office, or even in the school setting. The sooner that you screen for depression in this population, the better, because a lot of depression goes unnoticed, and untreated depression can lead to those risk factors that we talked about earlier in the project, including suicide attempts or completed suicide. And that is why the screening for depression is recommended in the ages 11 and older. Also, improved procedures, as this project showed. It was supposed to be completed already upon an initial evaluation, but nobody was doing the screening tools when patients were coming in. One issue is, a lot of turnover in these kinds of outpatient psychiatric clinics. Providers don't stay, or the nursing staff don't stay, and they're not familiar with the screening tool and the policies and procedures related to this. So it improved the procedures in this outpatient clinic. And this is something that should be getting done at any psychiatric outpatient setting. And another recommendation, improved access to mental health care. So as we know, there's a shortage of mental health providers, especially in rural areas. There's not many around, and the wait list can be very long. So providing more access to mental health care on a policy level is something that needs to be addressed. The telehealth extension for COVID-19 helped with patients being able to have access to mental health care. It's still being kind of evaluated whether that's something that's going to continue to stay around or not at this point in time. However, telehealth has really helped expand access to care for the mental health community, and I really feel it's necessary, especially being able to intervene sooner rather than later in this population that's more at risk. And these are all of my references. Thank you very much for listening to my presentation, and I hope you enjoyed it. Thank you.